Hey, all, welcome back to the Real Life Pharmacology Podcast. I'm your host, Pharmacist Eric Christensen. Thank you so much for listening today. Go check out reallifepharmacology.com. We got a free 31-page PDF on the top 200 drugs. It's a great study guide, great refresher, things that I see in practice all the time, as well as things that will likely show up on pharmacology exams and board exams. So that free 31-page PDF can be found at reallifepharmacology.com. Simply an email will get you access to that, so definitely a no-brainer to go snag that. We'll also get you updates when we have new podcasts and other content available as well. So definitely go seek that out at reallifepharmacology.com. All right, the drug of the day today is Midodrine. Brand name of this medication that I see most often is Proamotine. I will say at this point, Midodrine's been around a long time, so that's the more common name that I see utilized, which I'll use here. It is an alpha-1 adrenergic agonist. So this is going to have vasopressor type activities. So basically what it does is it closes or clamps down on those blood vessels. That's going to be the ultimate effect from this medication. Okay, so what would that potentially be useful for? Well, by stimulating those alpha-1 receptors, we're going to cause that vasoconstriction, and in a setting like orthostatic hypotension, that's symptomatic and clinically problematic, this is where that medication may be used for. There's a couple of disease states, too, that I see commonly anyway, that can cause some orthostasis. And again, as a pharmacist here, I would strongly encourage you to make sure to go through that medication list first and foremost and make sure medications aren't worsening orthostatic hypotension. Okay, so that's step one, and I'll talk about some of those medications coming up here. But once we, determine we're going to use Midodrine, we have some disease states that are more likely for a patient to experience orthostatic blood pressure, so lower blood pressure. So cirrhosis is a good example. Dialysis is a good example where we're kind of altering that fluid status for that patient. So those are a couple of things to kind of keep in mind there. Now, some of those agents that I wanted to mention. So obviously any type of blood pressure lowering medication, beta blockers, diuretics, ACE inhibitors, ARBs, and so on and so forth. Anything that can lower blood pressure, or we're using it to treat hypertension, that obviously has to be looked at first. If we're having a patient experience dizziness and symptomatic orthostatic hypotension, low blood pressure, address those blood pressure lowering agents first. There are a couple others that might fly under the radar. Parkinson's drugs can sometimes cause some orthostatic hypotension. As well as the disease state itself, patients are more prone there. Erectile dysfunction medications, another good example. So your sildenafil or brand name Viagra, that's a good example of a medication that can lower blood pressure. So making sure that we rule those out, really, really important thing to do there. Moving on to dosing, 2.5 to 10 milligram dosage forms. There's a 2.5, 5, and a 10. Typical starting dose that I see, particularly in geriatric patients, probably more 2.5. Occasionally you might see 5 milligrams started as well, up to 3 times a day. And then maximum typically recommended is going to be in that 10 milligrams, 3 times a day range. With dialysis, that's kind of a different animal a little bit, where this medication is sometimes used to reduce or prevent symptomatic hypotension during dialysis. So if you see Midodrine dosed 15 to 30 minutes prior to dialysis, you can probably anticipate that they're having some trouble through their dialysis session in that blood pressure is dropping too far and they're getting symptomatic, severe dizziness, syncope, those type of things. All right, adverse effect profile. So I would say, there's kind of some minor things that can happen. Goosebumps have actually been reported. That's also called piloerection, paresthesia, pruritus, itching. So there's kind of a few kind of nuisance type of things that maybe aren't major issues. But there's two really important ones that I think come up pretty consistently. Well, I guess I'll add a third here. So obviously this medication is meant to raise blood pressure. That blood pressure can get too high, okay, if we're too aggressive with the dosing and those type of things. So pay attention to that. The two other ones are bradycardia. So that can be an issue. So we're going to want to monitor that heart rate. And the other big one that I've seen in geriatric patients especially is urinary retention. So males who have BPH, urinary retention can already be a problem. So if we're adding this medication, that alpha agonist action can actually, tighten up that passageway basically and cause urinary retention symptoms to be worse. Okay, so really important to pay attention to that. Obviously, particularly more so in our male patients. A few things to be careful for, elaborating on that urinary retention. Kind of a case example I saw recently was we're actually needing a catheter for this resident because they had so much urinary retention, and we're using Midodrine to manage orthostatic hypotension. Okay, so that's a situation where, Midodrine's probably, or for sure causing more harm than good in that situation. So we need to find an alternative and those type of things. So, pay attention to that urinary retention issue. We've got to balance the cardiovascular risk. So if you've got a, severe cardiovascular patient, obviously if we get too aggressive, we raise that blood pressure, that's going to put them at risk for, cardiac concerns, stroke concerns, things of that nature too. So, pay attention to the cardiovascular risk and weighing that risk versus benefit there. A couple other rare things, pheochromocytoma, thyroid toxicosis. So, again, things that don't happen too often, but, have the tendency to potentially raise blood pressure and that be exacerbated from the use of Midodrine. A couple things on monitoring and kinetics. So obviously blood pressure, obviously heart rate. I alluded to the bradycardia risk potentially. Renal function, that is something that you probably want to monitor there, and that kind of ties in with kinetics. This medication actually is a prodrug, so it is converted to an active metabolite, and with that active metabolite is primarily renally eliminated through the kidneys. So you could imagine if a patient has poor renal function, we need to be a little bit more cautious with the dosing of this medication. So for initiating this medication, we definitely want to start at the lowest possible dose of 2.5 if they've got poor renal function. And that's generally, defined in this situation as, GFR less than 30 mils per minute. All right, let's take a quick break from our sponsors, and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like BCPS, NAPLEX, ambulatory care, geriatrics, BCMTMS, go check out meded101.com/store. We've helped thousands of pharmacists pass their board exams, and Meded 101 can absolutely help you as well. Find all those links, meded101.com/store. All right, wrapping up with drug interactions. So first thing I think about is Midodrine can raise blood pressure. So what other medications can raise blood pressure? So sympathomimetics, those type of medications, CNS stimulants, amphetamines, drugs with alpha-1 agonist activity, so a decongestant like pseudoephedrine. That's really what I think about first, okay? Then on the flip side, if we've got drugs that have alpha-blocking activity, so tamsulosin, doxazosin, that's doing the exact opposite effect of what we're trying to do with Midodrine. So again, pay attention to that. We may be able to reduce or stop orthostatic hypotension simply by getting rid of, let's say, doxazosin for prostate issues, or reducing the dose, or whatever the case may be, okay? So there's always kind of that risk versus benefit, and if we're using two medications that, are doing two opposite things on the same receptor, whether it's blocking it or stimulating it, that's a problem. And I mean, that's a classic example of, polypharmacy and the prescribing cascade. So again, pay attention to those drugs for sure. And then the others that I kind of alluded to a little bit, obviously any blood pressure lowering medication, and then some of those, Cinemet's a good example that can cause some orthostatic hypotension, and kind of counteract the effects of Midodrine. In a situation like that, there might not be anything we can do. We may need to manage those symptoms of Parkinson's disease, but making sure the dose is right and correct and we're not, overly aggressive, those type of things, that's important as well. Are there cardiac meds? Nitrates can certainly lower blood pressure as well, and kind of counteract what we're trying to do. The PDE5 inhibitors like sildenafil I mentioned, and even medications like antipsychotics can have some alpha blocking activity and cause some orthostasis, which would kind of directly oppose what we're trying to do with the use of Midodrine. The classic example, probably the antipsychotic that's one of the worst as far as causing orthostatic hypotension, is clozapine. That's definitely something I've seen come up on board exams a little bit here and there. So with that said, that's going to wrap up the podcast for today. Do me a huge favor. Go support the sponsor, med101.com/store. Tons of resources, books, links for nurses, pharmacy technicians, pharmacists, pharmacy students, all sorts of good stuff, all sorts of pharmacology type education. Please go support the sponsor, med101.com/store. If you love this podcast, if you found it helpful, please do me a huge favor. Leave a rating review on iTunes or wherever you're listening. And of course, feel free to drop me an email, mededucation101@gmail.com. If you got suggestions, questions, shoot me a message. I do my best to try to respond to all of those in a timely manner. With that said, thank you so much for listening. Take care and have a great rest of your day.